So today I'll be talking about management of long-term tunneled venous catheters. I'll try to keep to time. Is there a timer here? Okay. This show.
This icon. Full
Timer
screen
is
icon.
no slideshow, no, with timer.
The full screen icon.
नहीं, but with time. Timer है अपने पे. Okay. Just somebody tell me whenever the time is up because I know a lot of people there. ये अपने आप क्यों move कर रहा है? Okay. ठीक है. Right. So what exactly we call them central venous access devices or CVADs. So what exactly is this? I think all the critical care people are aware about these central venous access devices. So basically it's a special intravenous line and the tip of the catheter, it can either be inserted through a peripheral vein or through a central vein like IJV or subclavian. Or what is important is the tip of the catheter should be close to the heart, that is central in location, that is close to the cavo-atrial junction at the SVC or IVC and its junction with the right atrium. So very broadly, we can divide them into external catheters and implantable ports. So external catheters, obviously, some catheter which we can see externally. This also includes all our necklines, triple lumens, cava fix, everything is an external catheter. It's also a central venous access device, even though it is a short-term device. And most of them are non-cuffed, non-tunnel catheters. And a PICC line, which is a peripherally inserted central catheter, also comes under this. And then we also have these cuffed tunnel catheters. The most common of what we use in oncology is Hickman. And of course, we have the implantable ports. So indication for CVAD, I'm sure everybody here is aware. So definitely in an acutely sick patient, there are a whole lot of indications. And for intraoperative monitoring as well. But when we come to the oncology perspective, for giving chemotherapy and supportive care, we do use these central venous access devices because many of them, they lose their peripheral cannula. The veins are all blocked with the repeated cannulation. And also in some cases in children with thalassemia major, in some places they would put, especially in the West, they would put a Hickman catheter so that they can be given blood transfusions frequently every month till the time the child is able to go for a transplant. So definitely it improves the patient compliance. And not only that, having a central line in place, it also creates more productivity for the nurses who are caring, for the junior doctors. They don't have to spend a long time in trying to get a secure IV cannula, especially in an oncology patient who requires vesicant drugs or chemotherapy agents which can cause damage to the veins. So if you look at the peripherally inserted, we have the cava fix. This is how the PICC line looks. This is a child with a Hickman. And this, of course, is a chemo port. So these two are tunneled catheters, and this is a non-tunneled catheter. So how do we choose which one to, which kind of catheter to use? So I'll briefly tell you about each type of catheter for those who may not be used to. So PICC line, the biggest advantage is that it's just a little bit more invasive than a peripheral cannula. It's just like a cava fix that we put in the arm. If we put it under ultrasound guidance, then even if the veins are not visible, we are able to do it. And even for small children, we have an excellent PICC line team here, which is all managed by nurses, a team of around 10, 11 nurses, the insertion, care and maintenance, everything. And I'm quite proud to say that our charge nurse for a PICC line team, she can put a PICC line for even a 6-month-old child. So I don't have to step in to put a chemo port. So even infants, she is able to put a PICC line for small children. And over the years, I think because we have this line care team and we do the training and retraining of these nurses, the nurses of the hospital as well as the doctors, they are most comfortable with the PICC line. So if I ask any of the nurses, whether it's pediatric or adult, which line do you prefer? Everybody's always answered PICC line. The reason being, you don't have to access the port. There can be some error in accessing the needle, and there is no pain for the patient. Patient has a PICC line, you use your sterile aseptic techniques, you use the line straight away. So of course, disadvantages are there, then it requires a regular dressing and flushing. because it's external catheter, so definitely chances of infection are higher because there's contact with skin. So and it has to be kept dry. They have to take precaution while bathing. So which I feel that it is easily done with the arm. So and complications are usually very minimal because it's a peripheral vein which is being used. You won't get a pneumothorax after insertion of a PICC line. So this is how PICC line looks. And what we do is, how do we maintain it for so long? So ideally, what the company says is 6 months. We easily maintain it for 9 months and even up to 1 year, even in children. In fact, I feel because the pediatric nurses are a closed group, small numbers, more training, retraining, limited, only 3 nurses are there who will handle them. So somehow we see that the pediatric nurses, they're able to manage these lines much longer. Of course, our adult nurses also excellent. So what do? We use this stat lock, which is like something like a adhesive, instead of putting sutures, because sutures another source of infection. The other thing we do is transparent dressings, no gauze. If you put a gauze dressing, you have to change it every other day because it will create moisture, and wherever there's moisture, some bacteria will come. And the cleaning is done with chlorhexidine. So that is definitely superior. And with these kind of precautions, and of course, troubleshooting will be required. Now, subcutaneous port, a very brief thing. So basically, it is a central line. Usually, we access through the IJV or the subclavian, and it's a venous access device, either made of silicone or titanium, and we put it under the skin, usually in the infraclavicular area. We make a subcutaneous pocket, and the advantage is that the whole thing is inside. So the patient goes back home, even if they're coming from a remote area, they're coming back after 3 weeks for the next chemotherapy, no care is required. So it's the least maintenance that is required in a subcutaneous port. Of course, insertion is a surgical procedure, and we do it in the OT because we don't want any infections. So we like to do it with all aseptic precautions. And even for adults, I like to give some conscious sedation so that the patient is comfortable while we are putting, because somebody poking a needle in the neck and then working somewhere in the intraclavicular chest area for the next half an hour, 20 minutes, whatever, it can be daunting for any kind of patient. And this port disc, it can take up to 2,000 punctures, which is a lot, more than 10 years, even if you're flushing it once a month. Advantages, very minimal care. You need to flush it only once a month. Whereas PICC line, we had to flush it every week. And sometimes in children, twice a week, every 3 to 4 days. Easily, after the first few days, the wound is healed, the patient can bathe. And it's especially good for very good for breast cancer patients, because one side they have had a mastectomy and axillary clearance, so they have a lot of restrictions on that arm, and they should not lift any heavy weight. They cannot give that arm for sampling, blood sampling, no pricks, and blood pressure cuff cannot be tied on that hand. Now, the other hand you take and put a PICC line, then they have restrictions on that arm as well. So they feel very frustrated and psychologically upset. So when we put a chemo port, they are very comfortable, especially HER2 positive. They need the treatment for almost a year. So that's where it comes. Of course, the cost is more. So the initial cost is more. So we have to weigh both the pros and cons. And then in a child, for insertion as well as removal will require full general anesthesia. For adults, removal can be done under local anesthesia. It's just a 10-minute procedure. So disadvantage mainly is that it requires a skin prick with every. So again, hematological patients who are in and out of the hospital continuously, for them, we will avoid this. Their platelets may be low. And while you're pricking the needle of the chemo port, you're accessing the port, they can have bleeding. And also this needle, once it is put, we can keep it for 5 days and then we need to change. So I'll come to that a little later as to how the nurse in the ICU can manage a chemo port for a patient who has a pre-existing one. The third one is Hickman. These are the 3 most commonly tunneled and non-tunneled devices that we used. So this is, again, it's an external indwelling catheter. It is tunneled. Usually we put it under in the IJV or the subclavian, and there's a long tunnel in the pre-tunnel or the parasternal region medially. So this is how it looks. This Hickman has been inserted here in the IJV, and there's a little longish tunnel. I think this is not done by me. I like to put it a little bit medial to the nipple. I don't want to handle in the, of course, this is a boy, but even whatever it is, I try to keep it a little bit more medial. So again, Here there's a gauze dressing done. We can do a dressing without gauze. If it must be a recent one, that's why there's a gauze dressing. There's a double lumen. So the advantage of this is if ever we have a child who requires a bone marrow transplant, we have a double lumen catheter, a wide bore catheter much bigger than a PICC line. So there definitely is advantages. So again, this will require everyday flushing and once or twice a week dressing. So the care required is much, much more in a Hickman catheter. And that's how you can see the Hickman dressing being done. And this is how we do the cleaning protocol, center to periphery in a rotating manner with chlorhexidine. Right. So how do we decide? Depending on the age, depending on the duration of therapy, what is the frequency of access, and of course, what is the patient's desired lifestyle. So sometimes we do give them both options, and then the patient chooses. And of course, I have not mentioned here, but in a private setup, the cost also comes up. So as far as the cost is come, we take chemoport versus PICC line. After about 3 months duration, the cost of chemoport, which was initially higher, will become equal to that of maintenance of the PICC line because they have to come every week for the dressing. Especially if the patient otherwise does not require to come to the hospital, they don't have a weekly chemotherapy in that case. It's just showing, the dwell time of different types of venous access devices. PICC line 3 to 6 months, Hickman easily up to 1 year, and Portacath can be kept for more than 1 year, easily for 2 years, 3 years. The longest I have seen and removed is 15 years. It was inserted by somebody else. This is how a chemoport looks on the X-ray because it's all completely inserted. So we can't see it visibly external catheters. So usually there's a valve one which I use, and that again prevents the backflow of blood inside the catheter. And so it's much more easier. We don't need to lock it with heparin, and the blockage and infection is much, much less. So in the ICU setting, can we use these lines? The patient's already had a venous access device inserted. Now patient has surgery and is in the ICU for post-op care, or has had infection and is there for supportive care in the ICU. Definitely we can use these access devices for pain medications, antibiotics, TPN, immunotherapy if it is required as maintenance, hydration, even for blood sampling. In fact, now hospital for children, once they have a PICC line inserted, everything is done through the PICC line. We don't prick the children again, except for the contrast for CT MRI. For that, we need to do a peripheral cannula. So that way, the children become so comfortable. They don't hate the hospital. They love the ward. They come to the playroom. They are happy. Similarly, for adults, we have to make it more comfortable for the patient, whether it's a breast cancer lady with a breast cancer who's going through this whole chemotherapy. There's so much of psychological trauma. She's had a mastectomy. So why not make it more comfortable for them? So this decision should be given, this option should be given, and decision should be made in the beginning of the treatment, not when all the veins are gone, spoiled by chemotherapy, and then you're trying to get a line. So definitely, and of course, we use these lines for intraoperative management also, anesthetic management, but they need extra care. So what I do, we do regular training of the nurses almost at a monthly interval. I almost make them stand up and take an oath that they will, pledge to maintain their lines and take care of them till the whole duration of treatment is covered. So a very good nursing care is the backbone of a strong line care team. Insertion is not difficult. You learn it. We have courses for that, even for PICC line insertion, chemoport insertion. You can come and learn. Anybody can come and learn, and then you can do the insertion. But if you don't have a team of nurses to look after it, then the line will get infected. And then the most common problem that we face for a patient who goes to ICU and has a central line. So some of the units, they say, don't use the central line during surgery, don't use it in the ICU, because the ICU nurses are very busy, or maybe just that we are not training them as much as the ward nurses because they don't handle chemotherapy, right? And so we get a little higher incidence of CLABSI. The reason could also be that those patients who went to ICU actually had an infection. They already had some other source of infection, or they are immunocompromised, or they are more weak, or they're having some other complications of the treatment, or because of the tumor itself, the cancer itself. So aseptic precautions while handling the lines is very, very important, and that's what we emphasize for the nurses. Every time they change the IV solutions, they have to treat that line with respect. So we use clave connectors so that it can be easily scrubbed, and then wait scrub the hub for 15 seconds with chlorhexidine wipe and wait for 15 seconds and then connect. And wearing of sterile gloves or using aseptic technique to connect it is equally important, right? And even during dressing. So dressing of the lines is done by the line care team. So that bias we have eliminated, whether the patient is there in the ward or in the ICU or anywhere, or in the OPD, it is done by the line care team. So how frequently we have to flush? Once a week for PICC line and once a month for chemoport. Important to use only 10 ml syringe size because smaller size will cause damage to the catheter. It'll create unnecessary pressure. And there's a flushing technique. Always we tell them to check for blood return before flushing and avoid any air embolism as well. So pulse flushing, stop-start manner. This creates a positive pressure and a turbulence, and that will clear all the blood and everything that we do or any drug that we have given. So between two drugs also they flush. So flushing technique is something we make them practice on a mannequin, and that is also very important. So if somebody is done the flushing properly, the line should not get blocked. And if it is an open-ended catheter, we lock it with heparin at the end if we are sending off the patient home. If it is the Groshong, that is the valved catheter, there is no need for heparin. Just about 20 ml of pre-filled saline is what we use, again, to decrease the chances of infection. This is showing some complications. So any line that we have, complications are always possible. So it's not only the insertion technique that we have to learn the care and maintenance, and we have to be aware about the complications so that we can identify them and we can call the concerned people, and we should be able to handle it as well. So a little bit about CLABSI, which is central line associated bloodstream infection, also known as CRBSI now. So basically any venous access device, patient is immunocompromised, undergoing chemotherapy, they are prone to CLABSI. So CLABSI rates is something which we closely monitor, and that is something that is very important for us. So how do you define it? Laboratory confirmed bloodstream infection. So we do send a paired blood culture. We send one from the line and we send one from the periphery, and our microbiologists, they tell us which one grew earlier. So if there's a difference of more than 2 hours, more than equal to 2 hours, then we can know that the line is the culprit. Because if the patient's having a urosepsis or some other cause of septicemia, and there is the bacteria there in the blood, we are drawing the blood from the chemoport or from the PICC line, it will also contain the same amount of number of bacteria. It will grow something. It's not possible that the periphery has and the central line doesn't have. But to decide that the line is the culprit, we need the paired culture. If the patient is not sick and we do have a CLABSI, we do give a trial. We isolate the line, we put a peripheral cannula, we give appropriate antibiotics, try again for 1 week, even if the patient is in ICU but hemodynamically stable. Patient is hemodynamically unstable, or there is frank pus over there in the port pocket or something like that, then there have been times that I've removed the chemo port in the ICU itself because the patient's too sick, going into renal failure, multi-organ, so we don't have time for that. So it can be that dangerous. That's why just putting a line and not caring for it can be very dangerous. So prevention, of course, is much, much better, and hand hygiene, barrier precautions, chlorhexidine. Use of chlorhexidine has definitely improved our infection rates. So even for insertion, even for in the OT, I'm using chlorhexidine as the skin preparation. And for dressings, of course, they use that same. And of course, whenever you don't need a line, you remove it, and your checklist and your care bundles. Thank you so much for your time, and I'll be happy to take any questions if there are.
Thank you, Dr. Shalini. We have a question from Dr. Shagun.
That was a beautiful presentation. I have a small query. Many times in the OT, the patient comes to us with a port in C2 or even a PICC line in C2. And sometimes we don't have a non-coring needle to access the port. And there are times when for our patients, we are expecting a massive blood loss and we want to rush in fluids, So is it safe? Because there's a theoretical concern that if in such patients, if we put an IJV or a neck line, it might get entangled with the port or the PICC line either during insertion or during removal of the line. So you think it's a well-founded fear? Is it safe to insert these lines, or should we weigh the pros and cons and only then put it? Or is
Okay.
it safe? We can put it in all the patients with port or a PIC line.
So if you need a wide bore multiple lumen, like a triple lumen you need because of liver surgery or whatever, so then I think it's better to put another line. But what you can do is you can keep the tip of that catheter, the new line. You can get the C-arm to C, and so that you're not really entangling with the other line and not managing. But there is definitely a theoretical possibility. Touch wood, I've never seen one happen. And then, of course, we remove those lines early.
Yeah, because we've done it many times in the OT, but then we are always scared that it might get entangled.
So
So you mean we
usually-
should do it with real-time monitoring under
No,
CR
just at
guidance?
the time after you've inserted, it's always better before you fix it. If you can get the C-arm to see where your catheter tip position is, you can just withdraw it a little bit, let it be in the brachiocephalic. So usually the chemo port is on the right side if it's not a CA breast patient who is a right-sided breast lesion. And so if you're putting a left-sided IJV, it'll have a little curved course, and the tip will be not just about in the SVC or a little bit dipping. So if you keep it a little bit out in the brachiocephalic, you will get your intraoperative job will be done, and it won't hinder with that either. I think it's more challenging in a small child, and especially because the pediatric catheters are small and they are more soft and they can get entangled. I've seen one or two PIC lines getting entangled, but that was not because of another line, because of God knows what reason.
Thank you.
In fact, that was a very interesting question and a good answer to that. So I have one comment and a question. The comment is, in children, like whenever you put these chemo ports and these catheters, they are inserted basically in the intramammary area, more towards the outer side as compared to the inner side. And these children are quite mobile, as you rightly said, they go and play in the play area. So when you have to lift them, so you should not be using the axilla, because generally we lift the children from the axilla whenever the mother or the father or anyone else. So it is better to lift the children from the buttock, especially in the initial part when the chemo port is just inserted, because that can cause not only dislodgement but also pain in the child, which can reduce the confidence of the child in the treating team. And that is a comment. And a question is, what is your experience regarding CRBSI in your patients, like especially if you are treating adult ones with these catheters? Because
so it is calculated as I didn't put all that here because it would be too much. It's calculated as per 10,000 patient days. So the number of days the catheter is there, and I think what is the CDC is some less than 0.6 or something, or 1%. So ours is also something like that. In between, we did have some increase in infection rates. Earlier, it used to be 2%. Now it is 0.6. Ours is around 1%.
Okay. And do you allow, because generally what they say is that you should be keeping the area dry, especially in the initial 1 week after insertion of these catheters. So if the patient lands up in the ICU, do you advocate sponging and cleaning? I mean, what is your take on that?
If it
we need to keep it dry.
If it's a chemo port, 4-5 days have passed, I usually put absorbable sutures so that there's no hassle for the patient about that small wound. If somebody wants a neat wound, I will revise the scar at the time of removal, and I will give a subcuticular nice scar. At the time of insertion, I know they're going for chemotherapy immediately. So I give interrupted strong sutures. If the sutures are healed, they can wash it with water, soap, no problems at all. PIC line side, yes, because there's a transparent dressing. So beyond that dressing, definitely they can do the sponging.
Okay.
Yeah, but during bathing for PIC line, we ask them to wrap a clear film around that arm and elevate the arm while they are having a bath, so that direct water doesn't go.
Thank you. Thank you.
Thank you.